A very good evening to all my dear FMG friends, and a very warm welcome to today's session in which we are going to discuss 25 most important clinical questions for ophthalmology, which will be helping you to go through to revise your high yield topics in the subject. A very good evening to all of you, Aditi, Jensi, Vijay, Ahmed, Safina. I hope all of you are doing well, taking care of yourself, putting in the hard work which is needed at this point of time, and totally focusing on your upcoming exam. A very good evening to all of you. So here in ophthalmology, the questions which we are going to discuss, friends, is going to help you have an idea about what kind of questions are expected in the exam. In ophthalmology, in your previous exams, most of the time we are getting clinical questions, clinical case-based scenarios, image-based questions, questions based upon the surgery, instruments, etc. Okay, so that is the type of the questions which have been coming in the recent exams. A very good evening to all of you. I hope we are ready to start our session. Okay, right. So friends, please give this particular time now totally concentrating. Let's make it an interactive session. Okay, let's do the questions together and let's try to clear our doubts. All right. Okay friends, so I'm going to start with the first question here from a topic which has been asked many times in your exam. So the question is, a poorly controlled diabetic patient presents with sudden painless loss of vision with floaters. Which of the following could be the likely cause for this? Now, whenever you are doing clinical based question, always try to keep few things in the mind. Okay, always read the question statement very clearly. Try not to miss the key words which are there in the question. Read all your choices before making an answer, attempting an answer, because if you jump to one choice without reading the other choices, then it is going to be a problem. Okay, so in the question statement, see what is the age group of the patient, is there any systemic history, what are the symptoms, what kind of the vision loss is there, what all keywords you can see from here. So here in this question, a poorly controlled diabetic patient. Poorly controlled diabetic patient means that this patient is likely to have complications related to diabetes. Okay, sudden painless loss of vision. Now here the most important word is beta sudden. Sudden. Of course, in diabetes, most of the time the loss of the vision is painless, but here two words are very important: sudden and floaters. Okay, now coming to the choices. Snowflake cataract, cystoid macular edema, vitreous hemorrhage, neovascular glaucoma. Now, if you go one by one, snowflake cataract is a complication which occurs in diabetes due to the accumulation of sorbitol in the lens, which leads to the development of snowflake cataract. But cataract is always little progressive, it's never sudden. So snowflake cataract will not cause sudden loss of vision, and there is no reason for the floaters. So this is not the right choice here. Cystoid macular edema. Cystoid macular edema, again, it will cause loss of vision, but you do not see floaters, as well as the vision loss is always progressive. So this is not the choice here. Vitreous hemorrhage. So vitreous hemorrhage, when there is bleeding into the vitreous cavity from the new vessels, in a case of proliferative diabetic retinopathy, the bleeding is usually sudden. And whenever there are blood clots in the vitreous gel, the patient will see floaters. So both the things, sudden floaters, sudden loss of vision with floaters, is fitting into vitreous hemorrhage. So vitreous hemorrhage is the most likely choice over here. Neovascular glaucoma, another complication of advanced diabetic retinopathy, but you see most of the time when the pressure is very high, the patient will have painful red eye, and again the visual loss is not sudden, it is progressive, and there is no floaters. Okay, so choice C, very good. Most of you have marked the answer right. So choice C, vitreous hemorrhage, is the right answer. I hope you are clear why it is so. Okay, now coming to the diabetic retinopathy, this is how the vitreous hemorrhage looks like, my dear friends. You see all these blood clots which are there in the vitreous gel, they lead to floaters. The vision loss is sudden. The vitreous hemorrhage is occurring because of the bleeding from the new vessels, bleeding from the NVD or NVE, which is the proliferative diabetic retinopathy stage. Okay, so what will be the treatment? If there is a proliferative diabetic retinopathy stage, you have to do PRP. PRP laser will be the treatment. And if the vitreous hemorrhage is very dense and you cannot do the PRP and the vitreous hemorrhage is not resolving, then you might need to do pars plana vitrectomy. For the non-resolving vitreous hemorrhage, you might need to do pars plana vitrectomy. Now, if you want to quickly revise what are the complications of the advanced proliferative diabetic retinopathy, it can cause vitreous hemorrhage like this. Then it can also cause tractional retinal detachment, okay, and of course neovascular glaucoma. When there is neovascularization of the iris and the angle of the anterior chamber, there will be NVG or neovascular glaucoma. Okay. No, there will be no curtain fall in vitreous hemorrhage. Afsal, curtain fall is a sign of rhegmatogenous retinal detachment. Here it is just the floaters. The curtain fall is because when the detached retina is blocking the field of the vision, which happens in the rhegmatogenous retinal detachment, then there will be curtain fall. Okay, right? So, question based upon diabetic retinopathy, diagnosis, treatment, fundus image. So, please be sure to have an idea about that, right? Okay, coming to the next case scenario, friends. Next case scenarios, and let's read the clinical question statement over here. Now, a 70-year-old patient is planned for cataract surgery in left eye. His right eye had developed bullous keratopathy following cataract surgery. Which of the following investigation should be done before the surgery in this case? Okay. Now, again, coming to the question statement, reading it carefully. Elderly patient, 70 years old patient, an elderly patient being planned for cataract surgery in the left eye. Then there is a past history that in the right eye, the patient had developed bullous keratopathy. So, bullous keratopathy is a state of corneal decompensation in which there is bully formation on the cornea because of the corneal edema. Now, which of the following investigation should be done before planning surgery in the other eye here? Okay. What are the choices? Pachymetry, corneal tomography, specular microscopy, gonioscopy. Now, my dear friends, here the thing which you need to consider in your mind before attempting this question is you should know about bullous keratopathy following cataract surgery. Bullous keratopathy after cataract surgery. Now, why bullous keratopathy will occur after cataract surgery? So, cataract surgery, because of the surgical trauma, there can be damage to corneal endothelium. There will be damage to corneal endothelial cells. Some kind of minimal damage is there in every eye after the surgery. Okay. Now, corneal endothelium, you know, is the most metabolically active layer of the cornea, which helps in maintaining the cornea in dehydrated state. So, that is very important to control the corneal dehydration. So, if there is damage to the corneal endothelial cells, that leads to corneal decompensation. So, that leads to corneal decompensation, which leads to bullous keratopathy. So, corneal decompensation means the cornea becomes edematous. There is corneal edema. So, you get my point, friends? So, here you want to know that whether patient's corneal endothelium is healthy or not, and which is the investigation which will help in identifying whether there is a pre-existing corneal endothelial disease or not. Now, come back to this question, friends. Which of the investigation in these choices will help you to know about the health of the corneal endothelium, number of the corneal endothelial cells, or corneal morphology? So which is the investigations? Once again, it is specular microscopy. It is specular microscopy which tells us about corneal endothelial status, beta. So most likely this patient is a case of Fuchs endothelial dystrophy. This patient is a case of Fuchs endothelial dystrophy. Very good. So now all of you get that how this question needs to be attempted. Okay, very nice. Now your choices are correct. Pachymetry. Pachymetry is for corneal thickness. All right. Corneal tomography. Tomography is for corneal curvature as well as it also gives us corneal thickness. So tomography is investigation of the choice for keratoconus, for example. Okay. Gonioscopy. Gonioscopy where you want to examine the angle of the interior chamber. Okay. So if a patient has Fuchs endothelial dystrophy, this patient already has less number of the corneal endothelial cells, the corneal endothelial morphology is not normal, and if after cataract surgery there is further damage to corneal endothelial cells, that can lead to corneal decompensation and corneal edema. So in these patients, sometimes you have to, if the corneal endothelial cells are very low, you have to combine cataract surgery with keratoplasty. Okay, yeah, obviously corneoscopy has no role. Absolutely right, Dr. Devaki. Okay, okay, so wonderful. Are we clear about this, all of us? All right. Coming to next question, friends. Coming to next questions. Very good. So, who is going to tell me the answer for this? A diabetic patient presents with drooping of his right eyelid. On examination, his right pupil is dilated. What is the most likely cause of his condition? Okay. So, again, a diabetic patient. What are the symptoms? Drooping of his eyelid. So, what is the drooping of the eyelid? Ptosis. When you examine, you find his right pupil is also dilated. So, same eye, there is pupil involvement as well. Okay. What is the most likely cause of this condition? What is the most likely cause of this condition? Okay. Is it Horner syndrome? Is it third nerve palsy? Is it Adie's pupil? Or it is Argyll-Robertson pupil? Again, friends, do not jump to the answer. Do not jump to the answer. Okay. So, this is how your patient is. The patient has ptosis. Okay. The patient has ptosis. Now, ptosis will occur. Which muscle is the elevator of the eyelid? Which muscle is the elevator of the eyelid? LPS. So, it means there is some involvement of the LPS muscle. Okay. And when you are lifting the eye, you see that the pupil is dilated. Now, the pupillary fibers, the efferent fibers for the pupil reaction, they are carried by the third nerve. So, pupil involvement over here is indicating third nerve involvement. LPS is also supplied by third nerve. And if you carefully see here, the patient's eye is down and out. The patient's eye is in down and out position. Okay. So, when LPS is paralyzed because of the third nerve palsy, there is ptosis. When there is pupillary involvement, the pupil cannot dilate because the fibers the pupil cannot constrict because the fibers for the pupillary constriction, they are carried through the third nerve. So, pupil is in dilated position, and because of the paralysis of the all other muscles except lateral rectus and superior oblique, the eye is in down and out position. Okay. So, in Horner, yeah, as some of you are telling, the pupil will be myosed because in Horner, it's the dilator pupillae muscle which is paralyzed. Which is not occurring because of the sympathetic. The ptosis is because of the Muller muscle weakness. Okay, yeah, right, perfect. So in It's not that in all cases of third nerve palsy pupil involvement is there, but in some cases of the third nerve palsy the pupil involvement can be there, and here third nerve palsy is the right answer. So in Horner syndrome there will be mild ptosis and meiosis. Okay, in AD's pupil there is, in both these conditions there is no ptosis. In AD's pupil, the pupils, they are tonic. They are dilated, difficult to constrict, difficult to dilate. In AR pupil, it is light near dissociation. The pupil reacts to near reflex, accommodation reflex is present, but light reflex is absent. There is no ptosis. So, are we clear over here? Okay, right, perfect. So, no rush when you are attempting the question. At that point of the time, give your full attention to the question statement, and as I tell you, do not jump to the answer. Okay, so just try to rule out choice by choice. Just try to rule out choice by choice. Perfect. Okay, great, my dear friends. Okay, coming to an image based question, an instrument. So some of the instruments are important, and one of this is here. Identify the instrument shown in the given image. Identify the instrument shown in the given image. Let me pull out the image for you. So here you see there is an instrument which is being applied here. So which is this instrument? Which is this instrument? Any one of you, before even attempting the choices. This is your exophthalmometer. To be precise, it is Hertel's exophthalmometer. Hai na, friends? Now, coming to the choices. Exophthalmometer for proptosis, exophthalmometer for ptosis, Goldman tonometer for intraocular pressure, Schwartz tonometer for intraocular pressure. So here, this is your, as you have told me very nicely, it is your Hertel's exophthalmometer, and exophthalmo, as the word suggests, exophthalmos is another name for proptosis, which is protrusion of the eyeball. So this Hertel's exophthalmometer is for measurement of proptosis. Okay, so it is actually for the measurement of the position of the eyeball, whether it is displaced forward as in the cases of proptosis, or it is displaced inward, which can happen in the cases of anophthalmos. So ptosis is not measured with this. This is not tonometer. All of us are clear over here? TED हो सकता है, you are right. Thyroid eye disease is the most common cause of unilateral as well as bilateral proptosis in adults. Okay, and so of course it can be a thyroid eye disease patient. Just reminding you, because you can get an image for this as well. So what is this, beta? What is this image showing to you? There is a small probe which is touching the cornea. You are using the cobalt blue filter light. So which is this instrument? Yes. So this is Goldman tonometer. Goldman tonometer. Yes, for children, the most common cause of unilateral proptosis is orbital cellulitis. For bilateral proptosis, it is the chloroma or the neuroblastoma. Very nice, Dr. Debaki, Ambly, Barbie. Barbie, it's not gonioscope, beta. This is not gonioscope. So this is a probe which is touching cornea to applanate the cornea. This is Goldman applanation tonometry for intraocular pressure. So please keep this image also in mind. If you see there is a small probe which is touching the cornea, the patient is sitting on slit lamp because tonometer is attached to the slit lamp. You use fluorescent dye, that's why you are using cobalt blue light over here. So this is Goldman applanation tonometer, which is the gold standard for measuring intraocular pressure. Okay, and just for your reference, this one is where the instrument, a small handheld instrument which is again touching the cornea. This is Schwartz tonometer, beta. This is Schwartz tonometer. Though now the Schwartz tonometer, they are sort of obsolete. We are not using, because there are the measurement with this is very much dependent upon the person who is doing. Okay, Right. Fine. Yes, you will definitely get the PDF, my dear friends. But at the moment, let's concentrate on the discussion. Okay. So moving to the next question, friends. Moving to the next question. Again, the topic which is very favorite with the examiner, the topic based upon the extraocular muscles. So most of the time you have been getting one question related to the extraocular muscles or the movements of the eyeball. So here my question to you is, now again here do not jump, it's a very easy question, though it seems difficult. मुश्किल लग रहा है पर मुश्किल है नहीं है. You will see how easy it is. The question is, which of the following is not a pair of yoke muscles? Not a pair of yoke muscles. Now in questions like this, beta, not को नहीं भूलना है. Do not forget the not. Do not jump to, oh, कहीं yoke muscles तो नहीं करना है. No, not the pair of the yoke muscles. Okay. So for your choices, right superior rectus, left inferior oblique, left superior rectus, right inferior oblique, right inferior rectus, left inferior oblique, left inferior rectus, right superior oblique. Oh my God, I'm so happy all of you are doing it right, absolutely. So it means your concept for yoke muscles is absolutely clear. So what are yoke muscles? Okay, what are yoke muscles, beta? Yoke muscles are the muscles which one muscle in each eye. So one of them is there will be one muscle in the right eye, the other pair is the other muscle in the pair is in the left eye. So one muscle in each eye which is moving the eyes to the same direction. So if your eye is moving to left and up, so there will be a muscle in the left eye which is superior rectus and a muscle in the right eye which is inferior oblique, which is helping the eye to move left and up, which is known as levo elevation, as you are seeing here. Levo elevation. Okay. Similarly, there will be a muscle in right eye, levo depression. The levo depression will be right eye, inferior rectus, left eye, superior oblique. So this is actually dextrodepression, I wanted to say, dextrodepression. So one muscle in each eye which is moving the eye in the same direction. Now as in the class also, I always tell the most easy way to find out the pair of the yoke muscles is by a simple rule. So if, for example, if I start with the choice 1, so one muscle is right superior rectus. So to find that which will be the yoke muscle for this particular, the right will become left, the superior will become inferior, the rectus will become oblique. So this simple conversion will give you the yoke muscle for right superior rectus. है ना? So right superior rectus, left inferior oblique is there. So both of them, they are elevators. Both of them, they are elevators. Similarly, left superior rectus, right inferior oblique. But right inferior rectus and left inferior oblique, here inferior rectus is a depressor, so it is taking the eye downwards. Inferior oblique is an elevator. So this is not the right choice here. ठीक है जी? Right? Yes, absolutely right. I'm very happy with all of you guys with this question. Okay, moving on to the next one. Now here I just want to add, so you know about the yoke muscles. So if we have to know about the synergist muscles, synergist muscles are the muscle in the same eye. Synergist or agonist muscle is the muscle in the same eye which moves the eye in the same direction. Okay, which moves the eye in the same direction. So if you just concentrate on this eye at the moment, the left eye at the moment. So here the eye is seeing up. So what will be the synergist muscle for elevation in the left eye, beta? What will be the synergist muscles for elevation in the left eye? The synergist will be superior rectus and inferior oblique of the same eye. Superior rectus and inferior oblique of the same eye, because they are both moving the eye up. Okay. So superior rectus will be for the same eye where the movement is, beta. So I'm answering the question for Sundar. Sundar, if there is levo elevation, so if there is levo elevation over like, so on the same, levo means left, so on the same side, that is on the left side, it will be superior rectus. Okay. And on the other eye, it will be oblique muscle. So if you want to say, lateral will be the superior rectus. Okay. So, but easy to remember is for left elevation, left superior rectus, right inferior oblique. Okay. Right. Perfect. Great. All of you. Very nice. Now coming to another very simple but often asked question here. A young girl wishes to wear soft contact lenses for correction of refractive error. Which of the following or all of the following can develop with soft contact lens use if adequate care is not taken? Okay, except, so a person who is now going to wear the soft contact lenses. Okay, so if the adequate care or the hygiene with the contact lenses is not taken, all of these complications they can occur in this patient, but except which complication is not related to soft contact lens use. The choices are Pseudomonas keratitis, giant papillary conjunctivitis, acanthamoeba keratitis, phyllectanular keratoconjunctivitis. So indirectly this question is asking you what are the complications which can occur with soft contact lens use. Okay, so most of you are again right. The answer is phyllectanular keratoconjunctivitis. Okay, so you know soft contact lenses, if proper hygiene is not taken, proper cleaning of the lenses is not done, if people they use tap water to clean the lens or they shear the contact lenses, then infection can occur. And the most common cause of infective corneal ulcer in soft contact lenses is Pseudomonas. So Pseudomonas is most common in contact lens users, the most common infection. Okay, then acanthamoeba is the second most common. Okay, again contact lens use is the most common risk factor for acanthamoeba. Now some people they can develop allergy to soft contact lens use, which is in the form of giant papillary conjunctivitis. Okay, especially if you are wearing them for longer hours and you are, allergy can happen because of the hypersensitivity type 1 reaction. So that is giant papillary conjunctivitis. And as you told, phyllectanular keratoconjunctivitis is a hypersensitivity type 4 to tubercular or staph antigen. So this is not related to contact lens use. This is not related to contact lens use. Okay, right? So giant papillary, how would you differentiate if there is a case where you have to differentiate that whether it is a giant papillary conjunctivitis or infective keratitis, either Pseudomonas or acanthamoeba. So how would you differentiate this? If the question comes based upon this, how would you differentiate this? So the differentiation will be in the history beta. The differentiation will be in the history. You know conjunctivitis in itself will never cause decrease in vision. Okay, and there will be never severe pain. So if in the history you see that there is just mild discomfort, okay, so I will write no pain, no decreased vision. So if in the history there is no pain, no decreased vision, but symptoms related to allergy, watering, foreign body sensation, discomfort, mucoid discharge and giant papillae, then your diagnosis will be giant papillary conjunctivitis. Okay, then infective keratitis. So keratitis, whenever there is corneal ulcer, there will always be pain. Corneal ulcer is painful and there will always be decreased vision. So if in the history there is painful decreased vision, then you have to think of corneal involvement. Now whether it is Pseudomonas and acanthamoeba will depend upon the other features. Acanthamoeba, very, very painful ulcer, ring-shaped ulcer. Okay, Pseudomonas, a typical bacterial ulcer, but which is more prone to corneal perforation. Right? So Sago-Green of trachoma will, yeah, that can be another choice they can put to confuse, but of course that will again not be causing any pain. Okay, no, the summer disease is in cases of VKC. Dr. Sundar, the giant papillary conjunctivitis is because of the contact lens use. It has no relation to summer or any season. Okay. Yeah, adherent glaucoma can occur in pseudomonas because pseudomonas ulcers, they are at very high risk of getting perforation. Okay. Yes, there is a question on DCR. Don't worry. Okay. Okay, my dear friends. Moving on to the next question before that. Moving to the next question. A 48 years old man with uncontrolled hypertension presents with painful loss of vision in his right eye. It is actually the fundus photo of left eye. So let me correct this. In the left eye, I should say. Okay. So a 48 years old man with uncontrolled hypertension presents with painless loss of vision in the left eye. On examination, the fundus findings are as shown. This patient is at the risk of developing all of the following except. Now, this question wants you to make a diagnosis based upon the image and history. History is hypertension. Okay. Symptoms are painless loss of vision. Okay. And what are the fundus findings? What are the fundus findings? So, it's the fundus of the left eye beta. Okay. So, what are the fundus findings? And based upon the fundus findings, what is your diagnosis? Okay. So, for the fundus findings, first of all, please tell me the fundus diagnosis. So, you are seeing multiple retinal hemorrhages splattered all over the retina, flame-shaped hemorrhages as well as dot plot hemorrhages, which is giving a tomato splash appearance to retina. So, your diagnosis is central retinal vein occlusion. Agree with this? Okay. Now coming to this question. Now a patient who has central retinal vein occlusion will present with sudden painless loss of vision. Now what all can occur or what all complications they can occur in this patient except beta. Choices are malignant glaucoma, tractional retinal detachment, vitreous hemorrhage, neovascular glaucoma. Now just like in diabetic retinopathy, central retinal vein occlusion also causes ischemia of the retina. And whenever there is ischemia of the retina, there is production of vascular endothelial growth factor. Vascular endothelial growth factor secondary to retinal ischemia. So all those things which can happen because of the vascular endothelial growth factor, they can occur in a patient of CRVO. So because of the neovascularization, there can be vitreous hemorrhage. Because of the fibrovascular membrane formation, there can be tractional retinal detachment. Again, because of the neovessels on the iris as well as in the angle of anterior chamber, that is rubeosis iridosis or neovascularization of the angle, there can be neovascular glaucoma. So all these three complications, they can occur in a patient of central retinal vein occlusion. The neovascular glaucoma in cases of CRVO is also called 90-day glaucoma or 100-day glaucoma. Okay? But malignant glaucoma has no relation to central retinal vein occlusion. Okay? Malignant glaucoma is because of the aqueous misdirection. Malignant glaucoma is because of aqueous misdirection. So, in most of the time, it's a rare complication of cataract surgery or trabeculectomy surgery. So, malignant glaucoma has no relation to there. So, that is your answer of this question. Okay, beta? All of you are clear? Now, here, since we are doing a fundus image, so a quick recap of the different fundus images which can come in your exam. Okay, the one I just showed you, central retinal vein occlusion. So all of you made a very lovely diagnosis here. सबने बिल्कुल ठीक diagnosis किया. Whenever on the retina, you see that whole of the retina has multiple retinal hemorrhages. Okay. Now do not confuse this with vitreous hemorrhage. In vitreous hemorrhage, the blood clots, they are in the gel. So here you can see the blood spots, they are on the retina. So that will be central retinal vein occlusion. ठीक है जी. Moving to the another fundus diagnosis. When the retinal hemorrhages are there, multiple retinal hemorrhages are there, but they are limited to one segment of the retina, then it will be branch retinal vein occlusion, because just one branch vein is blocked. Okay, right? Now, when the picture is like this, that retina is appearing pale, you see the retina is appearing whitish or pale, and there is a cherry red spot, there is a cherry red spot, then your diagnosis is central retinal artery occlusion, central retinal artery occlusion. Okay, so all of you, if any of these images they come, you should be able to make the diagnosis. History in all of these will be same. All of these will be presenting with painless loss of vision, most of the time, which is again sudden. Okay, but based upon the fundus image, you can say. Now we can say, beta, we can say, see this part of the retina is little pinkish, but if you see this area which is whitish, sometimes it is more white. So you can get fundus picture of any type, and if you see a dark spot right in the center, which is the cherry red spot. So it's difficult to do, the only thing is the history, because here the history will be patient is a diabetic or atherosclerosis or a thromboembolic disease. With the other, like in Tay-Sachs disease, there will be muscle weakness, mental retardation, lipid storage diseases, they will have symptoms of their own. In Berlin's edema, there will be history of trauma, है ना? BRVO और पिज़्ज़ा चीज़ में बहुत डिफरेंस है बेटा. पिज़्ज़ा चीज़ में there will be whitish exudates as well. In pizza cheese, if I have to convert this to pizza cheese, the retinitis patches, they will have yellowish white exudates. Okay, because in CMV retinitis or in pizza cheese, there is retinitis which will appear whitish or yellowish like cheese, and then because of the hemorrhages from the vasculitis, there will be the blood spots appearing like tomato sauce or pizza sauce. Okay? Yeah, Berlin edema. In Berlin edema, because of the effect of the, you can say because of the pressure effect on the retina, there is retinal edema in blunt trauma. So again, it presents like that. The area of the edema is whitish, and in the center there is cherry red spot. Pizza cheese is for central, for CMV retinitis. Okay? Okay, so all of you are clear with all these differential diagnoses? Great. And I'm happy that you know that what all can be asked in the exam. So, perfect. Okay, beta, moving on to the next question. Bache. Again, a clinical case scenario. I have tried to put a lot of clinical case scenario because that covers the diseases in a very nice way. Okay. So here, a middle-aged lady presents with headache and menstrual irregularities. She has lost right side of visual field in right eye, left side of visual field in left eye. Which of the following could be the probable cause for her condition? ठीक है, again बेटा visual fields पे based question is expected. ठीक है नहीं, एग्जाम में भी सॉल्व हो जाएंगे बेटा. You have to just, because see, when you are doing exam, then there are, like, you are doing questions from all the subjects. So you have to see, you have to remember the points which you learned in ophthalmology. And of course, exam scenario is a little bit scenario of anxiety. ठीक है, anxiety होता है, थोड़ा pressure होता है. So थोड़ा सा एक calmness की ज़रूरत है. If you have read, अगर आपने पढ़ा है स्पेशली ऑप्थेल्मोलॉजी, अगर आपने कॉन्सेंट्रेट किया है what I have been telling you to look for the points, if you do that, you will be able to solve the question in exam also. Okay. And I can tell you from my experience and the experience from the past students that ophthalmology questions are like this only, from the topics like this only. Okay. The question can be a little different. They can ask just the image, they can ask just the management, they can ask just the diagnosis, but most of the time the topics, they are more or less the same. ठीक है? Okay, so after this, so yeah, so here first of all you have to identify what type of field defect is there. Okay, though you are already given me the answer, but just for discussing, for revising. So type of the visual field, right side of the right visual field. So this is your right eye, this is your right eye, this is your left eye. So right side of the right eye, left side of the left eye, means temporal field of both eyes is gone. So this is bitemporal hemianopia. All of you know. Okay, so bitemporal hemianopia occurs when there is some lesion in optic chiasma. To be precise, central part of optic chiasma, where the nasal fibers from both eyes, they are crossing. And optic chiasma area is an area which is in vicinity of the pituitary gland. So the large tumors of the pituitary gland, they can compress optic chiasma. Okay, so most likely, now given upon the history, this patient who is having headache and menstrual irregularities is having pituitary adenoma, and because of the hormonal problems, the patient is having these kind of the symptoms. So here your answer is pituitary adenoma, as you told. Now other choices, occipital lobe. Occipital lobe lesion will cause homonymous hemianopia with central sparing or macula sparing. Okay, temporal lobe lesions, they will cause superior quadrantopia or pie in the sky. Idiopathic benign hypertension or idiopathic benign, this is also called as pseudotumor cerebri, but idiopathic benign hypertension or intracranial hypertension is the most precise diagnosis. So here the patient has papilledema. Okay, so here the patient has papilledema. So in papilledema, what kind of field defect we see? In papilledema, we see blind spot enlargement. Blind spot enlargement. Right? So if there is a question based upon the defect, visual field defect in papilledema, that will be blind spot enlargement. All right? And so rapid revision is already available, beta. Okay, so just a quick review. So just a quick review of all the visual field defects here. So everyone with me, if the field defect is just on one side and it's a central scotoma, then most likely the site of the lesion is macula, right? If there is complete uniocular or monoocular vision loss, then the site is optic nerve. So in the question statement, you have to see whether they are saying right eye vision loss. If it is right eye vision loss, then it will be optic nerve. But in case they say right-sided field loss, so right-sided field loss means right half of the field is gone in both eyes. So this is very important to differentiate for the questions. Okay, so right eye field loss, optic nerve. Right-sided field loss means right half of the field in both eyes is gone. So that is a type of homonymous hemianopia. Okay, friends, I hope I am clear. So here, coming back here, if there is bitemporal hemianopia, the temporal field of both eyes is gone. So as you just told me, the lesion is in optic chiasma. Most common pituitary tumors like pituitary adenoma or craniopharyngioma. If there is loss of vision on the same half in both eyes, so here it is left-sided homonymous hemianopia. The left half of the field of vision is gone in both eyes. Okay, so this is homonymous hemianopia. So in these cases, if there is no central sparing, then the lesion is in optic tract, contralateral optic tract. Okay. If it is left-sided homonymous hemianopia, like in this case, the lesion will be in right optic tract. Okay. Now, pie in the sky, superior quadrantic defect, the lesion is in the temporal lobe. Pie on the floor, inferior quadrantic defect, the lesion is in the parietal lobe. And when there is homonymous hemianopia but with central sparing, as you see here, then the lesion is in occipital cortex or occipital lobe. All right. So a quick recap, do not confuse yourself with unnecessary details. If you remember this chart, you should be able to do the question based upon visual fields. ठीक है जी? Right? Okay, perfect. Coming to the next question, bache. Coming to next question, which of the following surgery does not need 10-0 nylon sutures? Which of the following surgery? Because recently the questions based upon surgery and especially the cataract surgery, they have been coming, bache, in the exam. Okay, so be prepared for that. Which of the following surgery does not need 10-0 nylon suture? Choices are conventional extracapsular cataract extraction, intracapsular cataract extraction, that is ICCE, penetrating keratoplasty, pterygium excision with conjunctival autograft. LGB wala is beta keyhole visual field defect. Dr. Anil, Dr. Amal. So homonymous ka right left hai beta. If the field defect is right sided, that is the right half of the field is gone in both eyes, so it will be right sided homonymous hemianopia and the lesion will be in the left optic tract. Okay. Okay, so 10-0 nylon sutures, they are used beta for corneal scleral suturing. Okay, for the corneal suturing, the 10-0 nylon sutures are needed. So here, in which of the choice you do not do that? And you are telling me very nicely, very correct, pterygium excision with conjunctival autograft. For extracapsular cataract extraction, conventional manual method, because there is a large incision, so you need to put corneal sutures. In intracapsular cataract extraction, a very large incision, close to nearly, you can say 10 to 12 millimeter. For ECC, mostly it is around 8 millimeter. So you have to use 10-0 nylon sutures. Penetrating keratoplasty, where you are suturing a full thickness graft with the host tissue, you have to do 10-0 nylon. For pterygium excision, when you are putting conjunctival autograft, nowadays you don't even need to do any suturing. You can use autologous serum or even tissue adhesive to do the suturing, to adhere the graft. Okay, so you do not need 10-0 nylon sutures over there. Right? So just to show you, because they can show you an image also and ask what is this. So here, as you see, the corneal button is all over. You can multiple sutures, 360-degree 10-0 nylon sutures, they have been applied. So this is a case of penetrating keratoplasty. Okay, so this is the case of penetrating keratoplasty. This is how the sutures, they will be applied. Okay, and this is the corneal incision, corneal scleral incision done for ECCE, extracapsular cataract extraction. Again, you can see multiple sutures, they have been applied. Similarly, if there is ICC, there will be still bigger incision and the sutures, they will be applied. Okay? Penetrating means full thickness beta. Okay? Now, the surgeries where you don't need sutures, as far as the cataract surgeries they are concerned, so they include small incision cataract surgery. Most of the time, the manual small incision cataract surgery, it's a self-sealing incision. Similarly, phacoemulsification, femtosecond laser assisted surgery, we do not need to do the suturing because the incisions, they are small and they are self-sealing. Okay. Intact means beta? I did not get that. Okay, right? Okay, moving on to the next question, bache. Identify the lesion shown in both eyes of an infant who recently had measles. The child is also underweight for his age and is from a poor socio-economic background. Again, a very simple question, but has been often asked in your exam. So this can be an image-based question, as I just told you. It can be just a question based upon the history. So patient who has measles. So measles most of the time leads to malnourishment. Okay, it leads to nutritional deficiencies. Then Child is also underweight, poor socioeconomic status, and if you see this image, you should be able to make a diagnosis based upon the image itself. So what are we seeing? We are seeing 5 foamy spots on the bulbar conjunctiva on both eyes. This is Behcet spot, as you told me. Okay, so the diagnosis and or the right answer over here is Behcet spot. The other choice is temporal pterygium. Now, pterygium is a growth of conjunctiva. It's a fold of conjunctiva which will be covering the cornea. It doesn't have any relation to nutritional deficiencies. Similarly, pinicula. Pinicula is again a conjunctival degeneration. No relation to nutritional deficiency. Horner Tranter spots, they are seen in VKC, vernal keratoconjunctivitis or spring catarrh. So this is here your Behcet spot. The questions related to, see, most of the time they're not going to ask that whether it is X1B or not. I have not seen question in FMG related to that, but yes, you should know what is the WHO classification. The first symptom is your night blindness. First sign is conjunctival xerosis or dryness of the conjunctiva, then Behcet spots like this, then corneal xerosis, that is extreme dryness of cornea, then keratomalacia, which can be less than 1/3 or more than 1/3. Next stage, then because of the keratomalacia or corneal ulceration can lead to corneal scar, and in the retina or in the fundus you can see pigmentary changes which are called xerophthalmic fundus, and all of these, they are because of vitamin A deficiency, which is more common in malnourished children, people from poor socioeconomic background. Okay, right? Okay, perfect, my dear friends. Moving on to next question here. Which of the following is not used to protect cornea? So I hope you are able to see this cornea here. Which of the following is not used to protect cornea endothelium during emulsification, phacoemulsification? So again, a surgery based question. I have tried to put 1 or 2 over here because, yeah, so they have asked the exact question so many times. You are very right. So coming to this beta, during phacoemulsification, that is during cataract surgery, which of the following is not used to protect corneal endothelium? Your choices are trypan blue, chondroitin sulfate, sodium hyaluronate, methyl cellulose. So why do we need to protect corneal endothelium? I just told you in the beginning कि cataract surgery के time पे there is some amount of minimal corneal the trauma to the corneal endothelium. Okay, so it's better that you use a kind of a coating agent or a viscous agent to coat corneal endothelium. So these agents, they are called viscoelastic substances. Okay, so viscoelastic substances, they help to protect corneal endothelium. Okay, so your answer should be, so beta here, choice B, C and D, all 3 are types of viscoelastic substances. Viscoelastic substances which we use during the intraocular surgeries, phacoemulsification, cataract surgeries. So this is not the answer. Trypan blue, which is a dye. So a dye has no role to protect corneal endothelium. Okay, so trypan blue is a dye which is used to stain the anterior lens capsule. Okay, so this is used to stain anterior lens capsule during surgery when cataract is mature and you want to do capsulorhexis or capsulotomy. That will assist in this. ठीक है जी, right? So coming to little bit about the things which they can ask based upon cataract surgery, but all kind of substances which we are using. So in the past there has been a question based upon anesthesia for cataract surgery. So if you are using local anesthesia, that you are giving an injection in peribulbar or retrobulbar area, then the drugs which are used, we use 2% xylocaine, also called lignocaine, along with 0.5% bupivacaine. Okay? If you are doing topical anesthesia, which is the anesthesia of the choice, especially for phaco or for flax, so just the eye drops, topical anesthesia. So the drug of the choice is 0.5% proparacaine beta, proparacaine. Okay? So this is about anesthesia for cataract surgery. Then when you are doing cataract surgery, there should be an irrigating solution or a fluid which is going constantly within the anterior chamber to replace the aqueous. So the solutions which can be used is, it can be BSS. BSS means balanced salt solution, but it is more expensive. So we can also use ringer lactate. So ringer lactate or BSS are the ideal irrigating solutions. Then viscoelastics. So viscoelastics, they include sodium hyaluronate, methyl cellulose, chondroitin sulfate. There is available combination of these as well. The importance of the viscoelastic is, number one, yes, of course, to protect corneal endothelium, then to assist during the surgery. So when you make an incision, the aqueous comes out, है ना? जब aqueous बाहर आ गया तो interior chamber collapse कर जाएगा. So to maintain the interior chamber, you put these viscoelastic substances which stay. So during the capsulotomy, during the insertion of the intraocular lens, so you are filling the anterior chamber with viscoelastics. So once the surgery is completed, they are washed away. Okay. Then dye to stain interior capsule of lens, we told Trypan blue. ठीक है, तो ये छोटी छोटी बातें related to cataract surgery please remember because they can be asked in the exam बच्चे. ठीक है. Moving on to the next question. A 17 years old girl has a far point of 100 centimeter and a near point of 25 centimeter. Which of the following error or refractive error is expected in this case? ठीक है. Far point of 100 centimeter and near point of 25 centimeter. What is the type of the refractive error in this case, bache? Okay. Now, when a person is not able to see far, so what type of the refractive error is there? Myopia, absolutely right. Okay, so when here basically you should know what is the normal far point. What is the far point in a normal eye? A far point of a normal eye कहाँ तक देख सकते हैं बेटा आप? You can see till infinity, है ना? You can look at the stars. अगर आपको कोई refractive error नहीं है तो बिना किसी glasses या contact lenses के you can look at the stars. So your far point in the normal eye is infinity. If the far point is reduced, okay, so if the far point is reduced, it means the person is not able to look at far or distance, then the refractive error is myopia. ठीक है? Near point of the normal eye is, using our accommodation, it is 25 centimeter. So a normal young person will be able to see clearly if anything is kept at 25 centimeter from the eye. Okay, but with age, there is loss of accommodation. Similarly, in hypermetropes, their near point is farther. Okay, so then you are not able to see, your near point can be 40 centimeter, 50 centimeter, and like that. Okay, so near point will be farther in hypermetropia, or in presbyopia. The far point is reduced in myopia. Okay, so here the question is asking you if the far point is 100 centimeter, so the answer is myopia. Okay, and what is amblyopia? Amblyopia is suppression of the vision when there is no organic cause for that. The suppression of the vision can be because of uncorrected refractive error, because of anisometropia, or because of strabismus. Okay? Right. Yes. Oh, that's great. Okay, perfect, beta. Moving on to the next very simple question. All of the following can cause foreign body sensation and watering from the eye except. Simple question, but do expect simple questions in the exam also, bache. All of the following can cause foreign body sensation and watering from the eyes except trichiasis, dystrichiasis, hypertrichosis, entropion. Okay? So foreign body, as if something is there, something is irritating the eye surface, and watering. Only one answer so far. Dr. Gupta. Yes, perfect. Perfect. So hypertrichosis is the answer here, beta. Okay. So these small terms you should know. What is trichiasis? What is hypertrichosis? What is dystrichiasis? So coming to all these terms, let's revise with the image. So this is what you are seeing. You are seeing that the eyelashes, they are turned inside and they are rubbing on the eye surface, ocular surface, on cornea, on conjunctiva. So this will be causing foreign body sensation and watering. So misdirected eyelashes is your trichiasis. ठीक है जी, right? Now, when there is an extra row of the lashes, so this extra row of the lashes is again misdirected and it is rubbing to the eye surface. So this misdirected extra row of the lashes is dystichiasis. Extra row of the lashes, which is coming from the openings of the meibomian glands. Okay? This figure here. So again you are seeing that the eyelashes, they are curved towards the eye surface, but here very carefully you have to notice that whole of the lid margin is also enrolled. So enrolling or inward rolling of the lid margin is your entropion. So again when lid margin is enrolled, so that will lead to rubbing of the eye surface. And what is hypertrichosis or trichomegaly? So do you see the difference in the eyelashes of these two eyes? So this is appearing normal length and density, and this is hypertrichosis or trichomegaly, in which the number and the length of the eyelashes is increased. Hypertrichosis. Most of the time it is because of the side effect of some drugs. Most of the time it is because of the side effects of some drugs, and most commonly prostaglandin analogs. Besides that, even phenytoin can very commonly cause hypertrichosis. So here the lashes, they are not rubbing the eye surface. So there is no problem of watering or foreign body sensation. Okay? Right? So simple question, but you should know sometimes they can be asked based upon the images also. So we should know how the trichiasis, dystichiasis, entropion looks like. Of course, hypertrichosis, how it looks like. Ready? Okay. Oh, so the next question is based upon the side effects of the prostaglandin analogs only. So which of the following is not a side effect of prostaglandin analogs when used to decrease the intraocular pressure? Again, beta, anti-glaucoma drugs. Okay, anti-glaucoma drugs, do remember, very important topic. Anti-glaucoma drugs, very important topic. Okay, so side effects, indications, you should know about this. So here we are talking about prostaglandin analogs. So choices are worsening of bronchial asthma, worsening of cystoid macular edema, hypertrichosis, increased iris pigmentation. Beta, read your choices carefully and then tell me the answer. Read your choices carefully. Yes, worsening of bronchial asthma is not the side effect of prostaglandin analogs. It is the side effects of beta blockers. For example, timolol. Okay, the rest all hypertrichosis अभी हमने बात करी. Increased iris pigmentation. It makes the iris darker. Okay, so that leads to, if you are using it in one eye only, that can cause iris heterochromia. Then worsening of cystoid macular edema. So prostaglandin analogs, they are inflammatory mediators, prostaglandins in the body. So if there is macular edema, so they can worsen it. They can even cause cystoid macular edema. So that's why we do not give these agents when there is uveitis. They can cause uveitis as well. Okay? So BCD are the side effects. Bronchial asthma is seen with beta blockers. Besides this, beta blockers, they can also cause heart block. So beta blockers, they are contraindicated in asthma, in COPD, in heart block. Okay, and prostaglandins, they are contraindicated in uveitis, cystoid macular edema. Okay. Otherwise, prostaglandins are the first line drugs or the drug of the choice for control of intraocular pressure. Okay, right? So I'm sure if there is any question related to anti-glaucoma drugs, you should do a quick recap of the drugs there. So something to pull ourselves up. So we know, beta, some of you are writing to me also that, you know, the exam is there, there is anxiety. Some of you have attempted it earlier, couldn't go through, but you know, the best view of any valley will come, or of any mountain range will come after the hardest climb. Okay? So you are already very close to the peak there. So these few days, almost nearly 2 weeks which are there, so these are the time where you have to put in your hardest effort, and I'm sure the best view of the success will be within your range. Okay, so let's keep doing, let's not leave the momentum. At this point of the time, you should be rolling in full gear, in full speed, and together we are going to do it. Let's do it. डाउन नहीं करना है, डाउन नहीं करना है बेटा अपने आप को. दिस इज द टाइम टू पुल योरसेल्फ. ठीक है, लेट्स डू सम मोर क्वेश्चंस. A 50 years old lady is suffering from watering and occasional discharge from her left eye. Okay. On syringing, a hard block is noted and the mucus-filled fluid regurgitates from the opposite punctum. Which of the following procedures will be indicated in this case? Beta, ophtha recall hoga. So do a quick revision. Do a quick revision of the field topics. We are doing a lot of the topics during this session as well, so which will be helping you. इस मोमेंट पे गलतियां करने में कोई प्रॉब्लम नहीं है बेटा. इस पॉइंट पे अभी हम क्वेश्चंस कर रहे हैं. यू डू योर एमसीक्यू रिविजन्स. गलती करने में कोई प्रॉब्लम नहीं है, बट ट्राई टू सी कि आपने कहाँ गलती की एंड ट्राई टू रिमेंबर दैट पॉइंट. ओके, सो दैट इज व्हाट इज गोइंग टू हेल्प अस इन एग्जाम ना. और तो कोई चॉइस है नहीं है. सो दैट इज व्हाट इज गोइंग टू हेल्प. इफ यू अटेम्प्ट अ क्वेश्चन रॉन्ग, डोंट टेक इट टू योर हार्ट. अभी कोई प्रॉब्लम नहीं है. क्या गलत हुआ उस पॉइंट को याद रखें. दैट इज गोइंग टू हेल्प यू. सो हियर अ पेशेंट हु इज हैविंग वाटरिंग एंड डिस्चार्ज on syringing, so very important, a hard block is noted and the mucus filled fluid regurgitates from the opposite punctum. Now you should know beta the interpretation of the probing and syringing. So here, based upon this question, what is your diagnosis? So if there is a hard block, that should let you know that most likely it is a nasolacrimal duct obstruction. Okay, and the fluid is coming from the opposite punctum. So it means the canaliculi system is fine, but hard block is there. The fluid is not able to drain through the NLD. So that is NLD blockade or nasolacrimal duct obstruction. Okay, so that is NLDO obstruction. So when there is NLDO obstruction, and here it is an elderly lady, so what will be the treatment for that? The treatment for that is DCR, as you have told us. Okay, John's tube is a procedure which is done for canalicular obstruction. So here we are putting a glass tube to relieve the canalicular obstruction. There the John's tube, which is actually a part of conjunctivo DCR. So conjunctivo DCR is combined with John's tube. So that is for canalicular obstruction. Decreocystectomy. Cystectomy means removal of the lacrimal sac. So decreocystectomy is done when there is atony of lacrimal sac. It's the physiological pump failure or physiological obstruction, that there is no mechanical or anatomical obstruction. It's the lacrimal sac is not able to do its pump action, so you remove the lacrimal sac. That is decreocystectomy. But when there is nasolacrimal duct obstruction, the choice is decreocystorhinostomy. For canalicular obstructions, conjunctivo DCRs using John's tube. Okay, then DCR, as you know, DCR can be done by external incision. Okay, that is called external DCR, or it can be done endoscopically using laser. So that is endoscopic DCR. Fine. So somebody wanted to know about DCR. Okay, and if you want to quickly go through the findings of the syringing and probing we can do with the help of this image here. So here beta, what you do in the syringing and probing, first of all, with the probe you try to go through the puncta and then you try how far you can go. So if your probe passes without any resistance, so it means the passages, they are patent. And then if you do the syringing, so if you do the syringing here and the fluid passes through the lacrimal drainage system and the patient gets the fluid in the throat, that is, it means it's a patent lacrimal passage. It's a patent lacrimal passage. There is no obstruction. Fine. But if you are, when you are doing the syringing, the fluid comes back from the same punctum, So it means, so if it comes from the same punctum, it means there is a block in that canaliculus. So if the lower canaliculus is blocked, it will come from the lower canaliculus. If upper is blocked, it will come from the upper canaliculus. Okay. If the fluid comes back from the opposite punctum and you notice a soft block, then it is common canalicular obstruction. So this is the simplest way we can remember. Okay. If it comes from the opposite punctum and you notice a soft block, then it is common canalicular obstruction. The treatment is conjunctival DCR using John's tube, etc. Okay. And if it again comes from the opposite punctum, but you notice a hard block, because of the bony feel, then it is NLD obstruction. Okay, bache? This is complete NLD obstruction. So as you see here, sometimes it can be partial NLD obstruction as well. So if there is partial NLD obstruction, then the fluid will come out through the opposite punctum and some of the fluid will come in the oropharynx as well. Okay, right? So this is how you will interpret that, depending upon from where the fluid is coming back, whether it is a soft block or it is a hard block, you will get to know whether it is a canalicular obstruction or NLD obstruction. Okay? And yes, of course, for congenital NLD obstruction, there is a treatment protocol that up to 9 months you will do sac massage, up to 2 years of the age you will do 2 month mein you will do sac massage beta. 9 months. From 9 months to 4 years of the age, you will do probing and syringing. After 4 years of the age, you will do the DCR. Yeah, as you're right. Absolutely right. ठीक है बच्चे? Okay, moving to the next question, bache. Next question. A 5-year-old girl is diagnosed with refractive error of +3 diopter in the right eye, -0.5 diopter in the left eye. Her best corrected vision is 618 in the right eye, 66 in the left eye. What is the most appropriate management in this case? Again, a very simple question, bache. Many times you have done this. You know this. But sometimes because they put the question statement in a little complicated way, तो हमें लगता है कि हम कर नहीं पा रहे हैं या रिकॉल नहीं हो रहा है. तो फाइंडिंग क्या है? What is the key information? एक आई में +3 डायोप्टर है, दूसरी आई में -0.5 है. So there is a difference in the refractive error of the two eyes. ठीक है. अब इस difference in the refractive error of two eyes को हम क्या कहते हैं? What is the condition when the refractive error is significantly different in two eyes? That is called anisometropia. Okay, all of you know, then it is called anisometropia. Okay, and when after correction the vision in one eye is not getting to normal, it is not 6/6. So it means even after correction the vision is not improving, so vision is suppressed in that eye. So suppression of the vision is amblyopia. So this is a case of anisometropic amblyopia. It is a case of anisometropic amblyopia. And in a patient who is amblyopic, you have to do the occlusion therapy, where you will patch the better eye, the normal eye, so that the eye which is suppressed is stimulated. Okay? So all of you are telling me the right answer. So after giving the spectacle correction, you have to correct the refractive error, and then you will do occlusion therapy. Okay? There is no role in squint surgery in these cases. Before occlusion therapy, squint surgery will be done only if the child still has squint after correction. Contact lenses, they may be a better choice for anisometropia, but still you might need to do occlusion therapy, and it is difficult for a 5-year-old girl to use the contact lenses. Refractive surgery. So refractive surgery is only done when the refractive error becomes stable, and mostly it is after the age of 18 years. Okay. Now, in this question, the information or the things which you revise, you should know an isometropia kya hota hai, when usually the difference in the refractive error between the two eyes is more than 2.5 diopter. That is anisometropia. Anisometropia will be a cause of amblyopia. That is anisometropic amblyopia. Amblyopia, when even after correction, the vision is not normal, 618 in the right eye. So right eye is having amblyopia. So here you will do patching of the left eye to stimulate the vision in the right eye. Okay? So simple concept beta, but you should be able to have this concept in mind and then attempt your question. Okay guys, moving to another question. A child is brought by the parents with squint in the left eye. Okay, so a child, see the age group is the child, and then squint in the left eye on DDO. DDO is distant direct ophthalmoscopy. A white reflex is noted. So a white reflex on distant direct ophthalmoscopy is leukocoria. Okay. Lens is clear. Lens is clear means there is no cataract. Fundus examination shows a cauliflower-like intraocular mass. So leukocoria, intraocular mass in a child. ये दो चीजें बेटा जब इकट्ठी आ जाएं, leukocoria with intraocular mass, and sometimes they can also mention that there is calcification within the mass. ये दो चीजें जब इकट्ठी आ जाएं, so what should ring in your mind? Retinoblastoma. Okay, leukocoria, squint, intraocular mass, retinoblastoma is the choice. Now coming to the other choices, retinal detachment, total retinal detachment can also cause leukocoria. Okay, that is the DD of leukocoria, but in retinal detachment there is no intraocular mass. Old vitreous hemorrhage can also cause leukocoria. Okay, but again there will be no mass. Toxoplasma causes posterior uveitis, but there is no mass. So retinoblastoma is the answer here. So you should know the other DDs of leukocoria as well. There is no cataract. Cataract can also cause leukocoria, but it's mentioned the lens is clear. So the question based upon the presentation of retinoblastoma, you should know this is how the leukocoria looks like. The white reflex on distance direct ophthalmoscopy, here it is the normal reflex. If you will see, this white reflex is caused by this cauliflower-like mass which will show calcification. The diagnosis or the calcification can be seen on ultrasonography. Okay, the investigation of the choice to see whether there is optic nerve invasion or not, whether there is intracranial invasion or not, is MRI. So that will be the best investigation in these cases. And then the treatment is, if there is a large tumor which is filling more than 50% of the eyeball, or there is anterior segment invasion, enucleation. And for smaller tumors, you can do focal therapy with laser, cryotherapy or brachytherapy plus minus chemotherapy. ठीक है, right? तो ये सारा हमने summarize कर लिया है बच्चा. And optic nerve invasion is the most common cause of spread in retinoblastoma, which is a type of direct spread. Okay? When you do enucleation, always you have to take out the optic nerve stump along with that, because you want to check histopathologically. And what will you see in well-differentiated tumors in retinoblastoma? Flexner Wintersteiner rosette. ठीक है बेटा, cover हो गया सारा retinoblastoma. Should be able to attempt that. Yeah, so both true and pseudo rosettes, they can be seen, but then pseudo rosettes or hemorrhage rosettes, they can be present in other tumors as well. So Flexner Wintersteiner rosettes, they are specific of retinoblastoma. Okay, Beck regime, very good. Okay, beta? Okay, perfect. Coming to next question, bache. Identify the lesion shown in the given image. Image based question for you. Lesion shown in the given image. So this is your slit lamp image. So the findings, they are on the lens. You are seeing this whitish deposits, dandruff like deposits on the lens surface here. So what is your diagnosis, bache? What is your diagnosis? Choices are rosette cataract, pseudoexfoliation, Vossius ring, Kayser-Fleischer ring. Simple question for all of you. What is your choice? Rosette, pseudoexfoliation, Vossius ring, Kayser-Fleischer ring. This is beta pseudoexfoliation. So some of you are right, some of you are confusing it with Vossius ring. So so what you see over here, beta, the lens capsule is showing deposition of the fibrillary material. So it is appearing as if the lens epithelium is exfoliated, but it is a pseudo exfoliation. And this type of the lesion is actually called target sign. Okay. So Vossius ring is when there is a brownish ring on the lens surface. This is white dandruff-like material. So it is pseudo exfoliation, which can occur in pseudo exfoliation syndrome. Okay. These patients, they may have weak zonules and they can also develop pseudo-exfoliation glaucoma. Right? Yes, Vossius ring is a brownish pigment. Okay. So this is how the rosette cataract looks like. Multiple times the question has come on rosette cataract as well. And if there is a Vossius ring, then on the lens surface you will see a brown pigment like this because of the impression of the pupil margin. So this is your Vossius ring. Okay. And this is your KF ring, which is actually in the cornea, not on the lens. So that is a brownish yellowish ring because of the copper deposition, in the patients of Wilson's disease or chalcosis, that is in the descemet layer of the cornea. Okay, beta? Right? So all these points, they can be asked as image based questions also to you. Moving to the next question. A young man with a history of oral ulcers and erythema nodosum presents with painful red eye and decreased vision. So in the history, oral ulcers, erythema nodosum, skin lesions, painful red eye, decreased vision. So whenever there is painful red eye, decreased vision, beta, the DDs of painful red eye with decreased vision, they include corneal ulcer, they include anterior uveitis, acute angle closure glaucoma, optic neuritis. ठीक है, ये चार चीजें याद रखना बेटा. Whenever there is painful red eye with decreased vision, and then with the other findings you will make sure that what is the diagnosis. So corneal ulcers, anterior uveitis, acute angle closure glaucoma, optic neuritis. So here the slit lamp is showing you all the features of the anterior uveitis. So you see congestion, and here whenever you see irregular pupil because of posterior synecdoche, that is a giveaway for anterior uveitis. You are also seeing a hypopyon. In some cases you can see keretic precipitates, KPs. In the anterior chamber you will see aqueous cells and flare. So all these, they are signs of inflammation in the anterior chamber. So anterior uveitis is the diagnosis. Episcleritis is inflammation of superficial part of sclera. Keratoconjunctivitis will be cornea and conjunctival involvement. Herpetic keratitis mostly causing dendritic ulcer. So none of these are true. Okay. So this particular case is actually a case of Behcet's disease. So in uveitis you should know, especially when the uveitis is associated with systemic disease. So here the patient can have oral or genital ulcers, skin lesions like erythema nodosum, and anterior uveitis like picture. Okay. Similarly, ankylosing spondylitis, you can get a case scenario based upon that. So in ankylosing spondylitis, there is anterior uveitis with sacroiliitis, sacroiliac joint inflammation, right? So the history will be that there is back stiffness or lower back pain. तो इस तरह से आपको बेटा ये याद रखना है. Behcet is HLA-B5, very nice, and ankylosing spondylitis is HLA-B27. Perfect. All of you are so nice. ठीक है बच्चे? We can move to next question. Okay. Coming to the next question, बच्चे. Again, often asked question. Multiple times asked. All of you know the answer, but I have to put it here because this is the important clinical question. A man presents to emergency following a road traffic accident. His eye shows periorbital ecchymosis with enophthalmos. The imaging shows the following findings. What is the diagnosis in this case? So I think, yeah, so in Reiter syndrome, it will be arthritis. And then the Reiter also has urethritis and uveitis. ठीक है बच्चे? All of you. So, so this image is probably, you can even see with the closed eyes. So what we are seeing over here, teardrop sign. The orbital contents, they are herniating into the maxillary antrum because of the floor fracture, orbital floor fracture. It is called blowout fracture of the orbital floor. So this is your teardrop sign. So whenever there is orbital blowout fracture, there is enophthalmos. Okay, there is inward displacement of the eye. The eye can show bruising around the eyeball, subconjunctival hemorrhage. There can be diplopia because of the entrapment of the inferior rectus muscle, the limitation of elevation. So all these features because of the orbital floor fracture. And other choices you can very well rule out. This is not a lateral wall or medial wall. We are not seeing mandibular bone anywhere over here. So this should be a spot diagnosis for all of you. Correct? Bilkul badhiya. Okay, moving on to the next question, beta. Moving on to the next question. A 47 years old lady presents with following fundus findings. Her IOP is 19 millimeter of mercury. And visual fields, they show paracentral scotomas. What is the diagnosis in this case? So what are your findings? Pressure is 19 millimeter of mercury. What is the normal range of the pressure? 10 to 21. So pressure is normal. Visual fields, they show paracentral scotomas. And this is the fundus image which is shown to you. So you should be able to identify the changes in this optic disc, beta. Okay, so whenever you are looking at the optic disc, see the neuroretinal rim, see the optic cup. So if I mark the optic cup for you people, so this is the optic cup here, the vertical cupping, nearly about, you can say 0.6 to 0.7, I can say. Okay, and if you notice very carefully, there is even bayoneting of the vessels here, bayoneting of the vessels occurring here. Okay, so increased cupping, vertically oval cupping, bayoneting of the vessels, paracentral scotomas on the visual field. So this is indicative of glaucomatous optic atrophy, bache. Glaucomatous optic atrophy. Now here you might ask me कि मैम प्रेशर तो नॉर्मल है, 19 मिलीमीटर ऑफ मर्करी है ना, सो नॉर्मल प्रेशर है, बट दिस कैन बी अ नॉर्मल टेंशन ग्लाकोमा. Okay, so intraocular pressure is not the only criteria. So you have to see intraocular pressure, optic disc changes, and the visual field defects. So visual field defects and optic disc changes are abnormal in this patient. This patient has the pressure within the normal range, but even with the normal range pressure, this may be high for this particular eye. So this is normal tension glaucoma. Okay, right? So you should be able to see glaucomatous optic disc changes in the optic now. In papilledema, there will be blurring of the disc margins. Blurring of the disc margin, disc is swollen and there is no cup. Similarly, in optic neuritis, there will be same kind of the appearance, blurring of the disc margin and no cup. Hypertensive retinopathy. If there is optic nerve changes, they are again in the form of disc edema. So these are not the indications. All right, got it, bache? Great. Moving on to the next question. Now again the question based upon trauma beta, question based upon the mechanical injury, the foreign bodies in the eye, chemical injuries, they are important for you. So you should know about that. The clinical question here is a factory worker presents with iris heterochromia and progressively decreased vision. There is a past history of eye injury while working with hammer and chisel. Okay, so अगर आपको इस तरह के keywords मिल गए हैं बच्चे, hammer and chisel, so they are iron, metallic instruments. So it means there is some metallic foreign body or chance of some penetrating eye injury. Okay, so here this patient is developing iris heterochromia and decreased vision, and the injury is very old. So what can be the likely diagnosis in this case? Rosette cataract, retinal detachment, siderosis bulbi, traumatic endophthalmitis. So whenever there is metallic foreign body involved, so there can be a chances that that foreign body is retained inside the eye. Hammer and chisel indicates iron. So it means there is some iron foreign body which was missed out. And now that iron is getting deposited into the various tissues of the eye, causing pigmentation of the iris heterochromia, and because of the degeneration of the retinal photoreceptors, decrease in the vision. So these changes which occur because of the iron releasing from an retained intraocular foreign body is called siderosis bulbi. ठीक है? So ऐसे आपने बताया. Okay? So rosette cataract is in blunt trauma. Similarly, retinal detachment can occur in cases of injury, but there will not be iris heterochromia. Okay? Traumatic endophthalmitis. Endophthalmitis can occur because of the trauma, but then there will be the features of the uveitis, painful red eye, anterior uveitis, vitreous exudates, which is not seen in these cases. Okay? Right? So, siderosis bulbi is because of the iron deposition. So, iron can deposit in iris, cornea, lens, retina, and because of the retinal degeneration, there is decreased vision. Similarly, if it is a copper foreign body, if there is a copper foreign body, that causes chalcosis, and copper foreign body will have the copper releasing from it. So the features, they are same like as in Wilson's disease. There can be KF ring, there can be sunflower cataract. Okay. And as you are telling me, MRI is contraindicated whenever you are suspecting metallic foreign body. Okay. Wow, Dr. Debeki, I'm really impressed with you. Yes, Bacillus cereus is a very common causative organism for traumatic endophthalmitis. Perfect. Okay, right? Okay, bache. Moving on to the next question. A 32 years old man has noticed that his eyelids, they start drooping in the later part of the day. He also has intermittent diplopia. Application of ice packs to his eye by ophthalmology resident improved his ptosis. What is the likely diagnosis in this case? Okay. Again बच्चे, the question statement is telling you everything. सब कुछ question statement में लिखा हुआ है. Eyelids drooping in the later part of the day. It means the ptosis is intermittent or it is fluctuating. Okay. It is better in the morning, worse in the later part of the day. Intermittent double vision. Application of the ice packs improved the symptoms. So what is the diagnosis? So this happens only in one condition, which is myasthenia gravis. Because in myasthenia gravis, there is less acetylcholine available at neuromuscular junctions. So as the muscle fatigue sets in the later part of the day, the symptoms, they worsen. Okay. The symptoms, they get better when the patient has rested. Okay. Application of the ice packs. So ice packs when you apply the ice packs, there is more acetylcholine available at the neuromuscular junction. So this is before and this is after the application of the ice packs. You can see the ptosis has improved from A to B. Similarly, the other test, if you inject tensilon, edrophonium or neostigmine, so that will also increase the acetylcholine at the neuromuscular junction, so that will improve the symptoms. So myasthenia gravis is the only condition in which you will get intermittent ptosis, intermittent diplopia, because the other extraocular muscles are also involved, most commonly medial rectus, but these tests, they improve the symptoms in these patients. ठीक है बच्चे, right? Yeah, edrophonium is same as tansilon. So third nerve palsy or complicated ptosis will not cause intermittency. Similarly, myositis. So if there is inflammation of the muscles, so that will also not cause intermittency. So that is the key word over here, bache. Okay, right? Great. Moving to the next question. A patient presents with complaints of seeing colored halos. On seeing through a stenopic slit, her colored halos, they break. What is the likely etiology of her symptom? Okay. So patient who is having colored halos, but on stenopic slit, when it is looking through, the colored halos break. So this is what you are doing. You are doing FinCam test. You are doing FinCam test. This test for the colored halos is called FinCam test. So which condition the halos they break, bache? What is your answer over here? Perfect. Immature cortical cataract. So when the colored halos, they are because of the immature cortical cataract. So when the patient is looking through the slit, the halos they break. When it does not look through the slits, the halos they reappear. If they persist, then it is because of the acute angle closure glaucoma. Okay. So colored halos, there are 3 DDs of colored halos. You know, mucopurulent conjunctivitis. So mucopurulent conjunctivitis, and then the FinCam test tells us whether the halos they are because of immature cataract. So mostly it is the cortical type of the cataract which causes, or because of the acute congestive glaucoma or acute angle closure glaucoma. So if the halos they break, then it is cataract. If the halos they persist, then it is acute congestive glaucoma. Okay, ji? Absolutely right. Okay, and the halos they will be seen in immature cataract, beta, not in the mature cataract, because halos they appear when part of the lens fibers they are opaque or hydrated and the other lens fibers they are still clear. So mature cataract will not cause colored halos. Similarly, pigmentary glaucoma is an open angle type of glaucoma. So that also will not cause the colored halos. All right. Great. Now coming to the last question of the session, bache, coming to the last question of the session, a patient reports painful red eye, decreased vision 3 days following cataract surgery. On an examination, aqueous cells and flare with hypopyon is noted. Fundus examination shows vitreous exudates with poor view of the retina. Which of the following organism is likely to be the causative of this condition? Now, when there are large question statements, beta, I know they take time. So that is why you should practice, and we have practiced the clinical case scenario questions. Okay. So because they will consume time. So, but read them carefully. Patient, there is a history of cataract surgery. So 3 days before patient had cataract surgery, now there is painful decrease in the vision. There is aqueous cells and flare and hypopyon, means there is inflammation in the anterior chamber. Okay. There is vitreous exudates. It means there is inflammation in the vitreous chamber as well, in the inner fluids of the eye. So what is the diagnosis first of all? The diagnosis is endophthalmitis. Okay. So the diagnosis, when there is inflammation in the anterior chamber, in posterior chamber, in the inner fluids of the eye, then it is called endophthalmitis. Now 3 days after cataract surgery means it is acute endophthalmitis, because if the endophthalmitis occurs within 7 days of the surgery, then it is called acute. And which organism is the most commonly involved? It is your staph epidermidis. Okay? Staph epidermidis, absolutely right, all of you. Now, if you know, bache, if you know staph epidermidis is the common commensal of the conjunctiva on the eyelids. So, most of the time, it is the commensals which can cause the infection after the surgery. So, this is the commensal or the normal flora of the conjunctiva and on the lids. So most important prophylactic measure to prevent the endophthalmitis after the surgery is to do pre-operative povidone iodine antisepsis. ठीक है, आप antibiotics दे लीजिए pre-operatively, post-operatively, but the most effective prophylaxis to prevent is, because when you are cleaning the skin around the eyeball and the eyelids with iodine, when you are putting iodine drop in the conjunctiva, so you are preparing the eye, you are removing the commensals from there. Okay, so staph epidermidis is the commensal. So this is the most important step in antisepsis. ठीक है बच्चे, right? Yeah, so what will be the treatment for endophthalmitis? So if the vision is better than hand motions, then you will do intravitreal antibiotics. But if it is poor than hand motions, then you have to do the vitrectomy, bache. Okay, right? Perfect. Okay. So this was our session for today, bache, and I have tried to give you an overview and a quick revision of the type of the questions which we can get, the type of the topics which are important. So as you see here, the things which you have to do, just compiling everything for you. The questions based upon the fundus images, diabetic retinopathy, the questions based upon the cataract surgery, the surgical complications, the questions based upon the anti-glaucoma drugs, questions based upon your lid lesions, lacrimal system, right? Then questions from uveitis, questions related to corneal ulcers. So all these, they are very, very important. The questions related to your trauma and injuries, again an important topic. So these are the topics which we have done time and again, and these questions, they give you an idea about how you will match the images with the clinical history. So you see, most of the time you are getting history with some clue to the image. Very few will be coming as a spot image. Now regarding the percentage of the povidone, beta, 10% for the skin area and 5% for the conjunctival sac. Okay, so I'm very happy that this session was helpful to you. At this point of the time, there is lot of insecurity, lot of anxiety coming in, जो कि बिल्कुल normal है. Okay, but believe you can. You have been working for past so many months. Okay, 2 weeks more. Put your best foot forward. Put all your efforts there, and you will reach the peak of the success. Okay, I believe in all of you. You believe in yourself. I believe in your hard work, and we wish you all the best from the team Mist. From me, my blessings are with you. Keep doing the questions, bache. Keep doing the mock test. Keep doing the questions. Try to revise the points, the important points, time and again. And I'm sure each of you will do very well in the exam, and you will make all the ophtha questions clear, which are going to give you at least 15 marks for your exam. ठीक है बच्चे, right? Beta, the questions are not hard. So questions, they will appear. There can be one or two unexpected questions, but most of the questions are from the topics which we have discussed, beta. Okay? Yes, some of the topics which you just discussed are helpful for NEET PG as well. Okay? Right? So these are the topics which we discussed, and few topics which I just, side by side discussed with you. They are the ones which are expected in your exams, and they should done. But gaze controls are not necessary for your FMG. I would not want you to get confused at gaze controls at this point of time if you are preparing for FMG exam. Okay? Right? Yeah, so it is good to go. Good to go now. Okay, so thank you so much for such a wonderful interactive session. Okay. Wish you all the very best. Wish you all our blessings, and the whole team mist is there at your back. Thank you so much. Take care. Keep studying. Just remind yourself you are just few steps away from the peak of the success there. The life is going to give you a beautiful view once you reach at that peak. So don't leave the climb now. Thank you. Take care, everyone. Many, many blessings, beta. Thank you so much.